Hi, everyone. If you needed a third Alex for the day, that's me. Third accent of the day. I'll talk about internal fixation in infected node union, which sounds like a joke sometimes, but it's not, because sometimes there's another way. We've been through the modern approach to fracture-related infection, which is becoming, thankfully, more systematic. So I won't go into those details. And we are good in identifying our enemies. So we have infected metalwork, we have soft tissue problems usually. Sometimes we have stability issues as well. And we have the hidden enemy, the biofilm, that goes with all the bone that's dead or infected and our metalwork. And we have treatment algorithms for an infected node union with TBNL inside. We know we have to debride and take deep samples, sometimes creating a bone defect. We need to manage the dead space because the hematoma is food for bacteria. We need to stabilize and align the bone, as all of the other speakers today have said. And we need good soft tissue coverage if we want to treat infection. And based on the samples that we've taken, we need broad spectrum antibiotics at the beginning. When we have samples, we tailor the treatment to the specific bacteria that are causing the infection. Now, implants, apart from the bone defect treatment where we use frames for transport, are mainly useful to stabilize and align the bone. And in most cases, we know what to do. We like to take the metalwork out, ream the canal. We can use local antibiotics, stabilize, and treat the non-union and the infection. And in more complex cases, again, we have treatment protocols where we do a good debridement and maybe more complex treatments like bone transport that are very, very compatible with everyday living. This guy has a frame on while on bone transport, extreme example, but it can happen, and get good alignment. But sometimes decision-making is not that straightforward. So this patient of mine was 62 years old, without any injury, manual labor, he had no comorbidities. He went to a district general hospital and complaining of pain in his thigh and swelling and a bit of fever. He had an MRI, he had x-rays, he had those changes that you can see on the medial cortex and inside the canal. He had an abscess around it and a cortical breach. We asked Stanmore for an opinion and sarcoma was excluded. The local hospital did an aspiration and grew streptococcus. So he was referred to us. Now, the questions I have when I want to treat this are not so easy to answer. For example, if I debride the bone, and if I open a window medially, and if I clean the canal and remove what looks infected, the bone I have left, how long will it take to heal? The cortex I've removed, how long will it take to be replaced? And if I take a lot of cortex out, will it be stable enough to allow the patient to walk? Or am I risking a patient with a fracture while mobilizing? And if I have to stabilize it with an X-fix, how long? It's not a fracture, it's a debridement of an infected cortex without any clear etiology. How long will I have to leave the X-fix on for? In the thigh, it's not an easy thing to tolerate. And if it's not easy, can I use internal fixation? Possibly. And can I use local antibiotic delivery systems to protect my implant from the infection? So this is kind of the questions I have. For this particular guy, we did a good debridement. We reamed the canal with a RIA, and we don't use the RIA for bone grafting in this case. We use it to wash and suck out all the infected bone. We open the window on the medial side, and we fill the canal with antibiotic bullets. That's stimulant with Vanc and Gent. And Alex Trumpeter is here. We did the study together. We've seen that it's a very easy, reproducible, and safe way to deliver super high doses of antibiotics locally without risking the patients with renal problems or with other problems. Also, the combination of Vanc and Gent is broad spectrum, especially in the doses that you can achieve in there. In combination with the antibiotic profile, the bacterial profile of our patients. We studied 320. Our broad-spectrum guidelines with Tyke and Marrow after the operation until we get samples back. In combination with the local antibiotics, we think that are covering most of the potential pathogens. There are other ways. You can use implants coated with cement or plates or nails. The reason I'm not a big fan is after a few, like 3-4 weeks, they stop eluting and then it's just a plate that's a bit uglier. We have coated nails, which were very promising in prevention of infection, but we know that they elute antibiotics for about practically a few days. It's not the 4 or 6 weeks that usually promised. And the newer technology, we've started a study in the UK now, where Royal London is one of the centers recruiting, with the Bactiguard nail. This is a technology with gold, silver, and palladium coating on the nail that creates some microcurrents that do not allow the formation of a biofilm. So it looks like the implant industry is targeted towards infection in a way. Now, this patient did well. 12 months post-op, 9 months off antibiotics, no recurrence, no signs of infection. The bullets have been absorbed. But sometimes it's not so straightforward. Simon, you know the case from Nottingham. Different angle now. So sometimes it's not so straightforward. So I got this referral, and this is the system. We refer a patient that gets patients referred to us. Osteogenesis imperfecta, 17-year-old, with a femoral transverse fracture, and the canal was very narrow, and the nail couldn't go in, and the lateral cortex and neck were broken, and they didn't tell me that the patient was severely autistic as well. Happy days. And this is the imaging I had. Does anything look odd to you? Especially the pediatric surgeons here in the room? In this slide? I don't know, does osteogenesis imperfecta, does it look like that usually? So it's kind of, doesn't sound good. These are the images from the operation that the patient had before he was referred. So they managed to, apart from the fracture, they tried to ream retrograde because the fracture of the neck, the X-ray time was 11 hours and 17 minutes. That means the operating time was more than 12 hours, right? He had a massive incision from the GT to the knee. The neck is in a bit of varus and a lot of rotation. The fracture is not reduced. Anyway, so we thought we'd get the story straight. He did not have osteogenesis imperfecta. He had this condition. Don't know who, you guys know it? Yeah? Anyway, it's a condition that causes mainly problems with the bones. The bones are very brittle and very hard. They're like ceramic, right? They're very hard to drill, but if you drill, it might crack without any elasticity. And just to put some color to it, it's called Toulouse-Lautrec syndrome, French impressionist from the 19th century, hanging out in the cabarets of Paris, and he was doing those drawings that he's famous for. They might be familiar to you. He's the most famous patient with this syndrome. He was very short, and he could only get some prostitutes who really love him. And he was a bit of a rogue. Look, in the 19th century, to do this and take photos taking a shit on the beach is not... So, 11 hours, 12 hours of operating with those implants. I asked friends for help, of course. So my pediatric colleagues told me that they don't know what to do with this case, but the bone of these patients is very brittle, but you might need special drills to drill holes. It's not straightforward. So I ordered them. My colleagues in Stanmore told me that this neck, I shouldn't leave it like that, because if there's any chance to save the femoral head on a 17-year-old, I should give the patient that chance. So we went in and did this. We valgized the neck, filled that with CERAMENT G. We took samples by the book, 5 for microbiology and 2 for histology. retrograde humeral nail, just to be sure that it would fit, because of smaller size. We caused 2 more intraoperative fractures through the previous plate holes, being very careful, still we did that. And we broke a few drill bits trying to lock the nail. Anyway, 10 days later, he went home. And in the second follow-up, discharging wound, brown fluid, and we get a phone call from microbiology that, yeah, we didn't grow anything, but the 16S just came back. He has Klebsiella and Pseudomonas. Fantastic. So now, we're here. This patient with a discharging wound and Pseudomonas and Klebsiella 4 weeks after our operation. So who would leave this alone and just give antibiotics? Hands? No one. Would you debride and keep the metal hook in and give antibiotics? Thank you, Alex. Anyone else? Would you revise the whole thing and take everything out and put an X-fix? Exactly. That's my point. How can you X-fix this, right? Maybe this, but how long for? Will it ever heal? This guy has 1 million holes from the previous fixation. You add some X-fix pins, it might break anywhere. So we did a generous debridement, Vanc and Gent generous quantities, and then it gets worse. Still discharging, 4 debridements, and new acronyms that I've never heard about. DILI, drug-induced liver injury. The patient was getting worse, was getting septic, was getting tachycardic, had a weird presentation, but the wound was getting better. DILI, DRESS, this is a condition where you have drug like eosinophilia and systemic symptoms from your antibiotics. The respiratory guys thought he had septic emboli in his lungs, and the cardiologist thought he had septic emboli in his heart from a neglected PICC line. A bit of a thriller, and we managed to control everything with some very weird antibiotics. I don't remember the names. He's now, this X-ray is from May. This is 5 months after an operation with a quiet wound on antibiotics that cannot stay for too long. Okay, he cannot stay on them for too much longer. So we have to do something at some point. He's doing well. He's mobilizing. There's a bit of callus here. This fragment probably is dead, and this is periosteum around it, right? This, I'm hoping it will heal. And I'm planning to do a CT scan in about Monday in 2 weeks. What would you do? Please.
Just had a case. She's a Dutch. She's 41 years old, and she had infected manually with tibia.
Yeah.
With nail on. And 1 year, about 1 year, I did bone transport. And it went quite well. The site of lengthening was perfect. We had another case of one before the hospital, and she asked for cosmetic cleansing at the time.
With pycnodysostosis?
Yes.
Okay.
Before, and it heals nicely, so I thought it's okay if I do bone lengthening, and we did it, but she had a psychiatric problem, and you have to abandon the procedure after 1.5 months, but bone formed quite nicely. There was nothing, I know there was nothing, there are no reports in the literature about bone healing and pycnodysostosis or something, just brittle bone, but it's not as brittle as osteopetrosis.
No.
There's much, yeah, much.
I don't know, but this one
difference.
kind of was brittle.
Yeah.
Anyway.
But bone formation in osteopetrosis, it's forming almost normally, because in the 2 cases, the bone formation in the regenerate was almost normal, like other
good
people.
to know.
And they had fractures before, and it healed nicely.
Yeah. Anyway, my concerns is that this patient should never be left without any support, at least until his drill holes all heal, which might take 2 years. It's not fast. But at some point, I need to stop his antibiotics. I cannot leave him on antibiotics forever, and I've been warned by microbiology that the antibiotics he's on that are working cannot stay on for more than a few months longer. My point being that sometimes an external fixator with an indefinite duration of treatment is not an easy choice. Now, what happens in the tibia? I mean, in tibia, usually the decisions are kind of easier. X-fixes work, frames work, plasters work, casts, splints, and we tried to see if we can. We did a study with the ETN Protect, the Synthes antibiotic-coated tibia nail, and it did really well in preventing infection in open fractures, but it didn't do well at all in bone infection. So all the cases that were infected and we thought we had cleared the infection and we nailed them, they all recurred. So we haven't used it again. My points, because the clock is ticking, in infected non-unions, I would consider internal fixation. In difficult cases, especially in the femur and the upper limb, with good soft tissue coverage and good biology, always with the use of local antibiotic delivery systems, preferably absorbable, because I do not want them to end up cemented foreign bodies that could cause biofilm formation. And we have systems, and we've seen that the intramedullary antibiotics especially do not cause so much leaking like the ones we put under the soft tissues. So they're kind of complication-free, almost. This is why I prefer using plates in the femur and not nails, because I can fill the canal with antibiotics, manage the dead space, and deliver huge doses, and stabilize it with a plate that's easier to manage if it gets infected again. I would only do internal fixation if I trust the debridement that I did. And in cases where the patient will not tolerate a frame, either because of the patient or because I don't know how the frame will stay on for. And in the femur, pin site infections, especially the proximal pins, are very common. Now, things to consider are that we're talking about the biomechanical aspect of the non-union when we're talking about implants. It's not the biology of the non-union and not the treatment of the bacteria. But the stability that we provide sometimes is so beneficial to the recovery of the soft tissues and the treatment of the infection that it actually outweighs the risk of putting metalwork in there. We have to clarify that it's a different thing to have an infected non-union and leave the metalwork in than clean everything, remove everything, debride, and then put new, fresh, clean metalwork. And we always have to consider that either we put metalwork in that we leave forever, or we plan the removal when we stop the antibiotics, or we exchange it when we finish our treatment and do a second, smaller debridement. So yeah, with that in mind, I think there is an argument for using metalwork and implants in bone infection, internal fixation, being very, very, very careful how we decide and how we plan our treatment. Thanks.